Hi everyone. We're going to do the third part of Ask Us Anything About Therapy. So excited to be doing this. It's a year in the making. So excited to have people here. I know the hour is a little bit challenging for many, but this was the only time we were able to make work, and I certainly prefer that over not doing it at all. So thank you to those of you who've joined. I'm so curious how many of you have heard parts 1 and 2 of Ask Us Anything About Therapy that we did a year ago. Some of you may have watched it on YouTube. Some of you may have seen it when we did the actual live. Okay, Dr. Koslowitz just notified me she'll be a couple of minutes late. That's great. We'll start the conversation from here. So some of you are saying you had watched parts 1 and 2. It's not necessary. Somebody just asked me privately, is it necessary to watch part 1 and 2? Oh wow, there are a lot of questions that are coming in. Okay, was it necessary to watch part 1 and 2 to be able to get 3? No, not at all, actually. Parts 1 and 2 addressed questions that were asked last year, which many were excellent questions as well. And today's question load was quite extensive, should I say. We have quite a bunch. I'm not sure how many of them we will get through. We will try our best to cover as many of the questions as we can. So as I said, I'm waiting for Dr. Koslowitz to join us, but I just want to start to give this a little bit of context and I guess introduce myself, and then, we'll get into Dr. Koslowitz when she joins. So for those of you who don't know much about what we do, or for those of you who are new to following my page or have found me here through somewhere else, thank you for joining. My name is Rivkah Kohn. I run an organization called Links and Schleimies Club, which primarily services children and teens who've lost a parent. What started to happen a couple of years ago was what we realized that there was more needed for adults who had lost a parent. And so I started this page on Instagram, sort of as a way of providing education and support to those who had lost a parent. What I didn't realize I was getting into were a lot of broader conversations, as well as a lot of conversations with those who are supporting others who are in grief, whether it's a spouse, whether it's a sibling, whether it's a sibling-in-law. And there were a lot of interesting conversations that began happening. And over the last couple of years, I must say that I feel privileged to be in this space. There's a lot of incredible conversations that we've had, and really a lot of good work. So most of the lives these days I try to save on IGTV, and I say that with a laugh because every once in a while the technology gets the better of me. But in terms of the previous sessions to this, like parts 1 and 2 are saved on YouTube because that was before IGTV was a thing, where lives were only saved for 24 hours. So we used to have someone screen record it and then upload it to YouTube, so it's there for the forever space, like we call it. So today we're going to be going into a lot of the therapy questions that were sent. Let me just find out where Dr. Koslowitz is. She said she'll be on in a moment. So today's questions, actually, a friend of mine who's a clinician just messaged me a few minutes ago. She goes, are you really doing this live? Are you really going with those questions? And I said, of course. So she goes, then you're very brave. I don't think I'm brave as much as the fact that I believe that there's legitimacy to every single question that was asked. Obviously, we won't get to every single question, although it's certainly a goal of mine to cover as many as we can. I did try to kind of consolidate where I could, so to get to as many of the questions as we can. And we like to do it in a partnership, Dr. Koslowitz and I. I'm coming from the perspective, I am not a licensed mental health professional. I am simply someone who's been sort of in the field of helping people access mental health services through our therapy referrals and through case management and support. So in that sense, I've had a lot of exposure to how different clinicians work, how different modalities work and all that. And it's part of the conversation that we try to have on this page a lot. Dr. Koslowitz, who's going to be joining us, is a psychologist. She is based actually in Lakewood in New Jersey, and she's been on our team and has worked with us. So we've gotten to know each other's style and have been able to collaborate on something of this nature because she'll be coming from a clinical perspective, whereas I'll be repping some of the non-clinical sort of angles, okay? So we're just waiting for her to join in. While I do that, I want to ask 2 questions if you feel comfortable. Number 1 is, again, I'm just curious, not that this is in any way needed, but how many of you on here, like if we reference something that we did in part 1 and 2, how many of you watched that? Because there were a couple questions that I know we covered there that are going to be fundamental, like the fiduciary relationship. So if you were on for parts 1 or 2, or you watched it on YouTube, could you just give a thumbs up a second? I'm just curious where people are at with this. That's number 1. So let's just see first the answers to that. If you feel comfortable, guys, to just put like a thumbs up if you watched parts 1 and 2. I'm just curious. Okay. I see a couple people saying they have. For those of you who are joining now, we're just waiting for Dr. Koslowitz to join us. She'll be on in a couple of minutes. This was pretty last minute, so we're all trying to make this work. But I'm just curious in terms of those of you who, thank you. I'm seeing more thumbs up. Those of you who, okay, she's logging on now. Those of you who have watched parts 1 and 2, again, not necessary. I'm just gonna sort of reflect on a couple of things that was said. I know it was a year ago. I don't expect you to remember, and I certainly won't quiz you on it. But then we're going to go into the new set of questions. What I found fascinating is I think that the questions that we got now, some of them obviously are really difficult questions, frankly, like the kind that I would love to say, oh, that we're not covering today, because they just kind of are hard, shall I say. And then there are questions where I think they're just deeper maybe than last time. There's a part of them that's just a deeper thing. And I think that has a lot to do with what's been happening, in my opinion, on Instagram recently, which is, I'm grateful to see it. More mental health professionals, and I see some of you who have joined us here, are joining Instagram and are able to make a dent in the education and how people perceive these different, here we go, Dr. Koslowitz is here. I sent you a request. That's funny. Did you get my request, Dr. Koslowitz? Are you able to join? Oh, whoopsie. We are on.
Hello.
Okay. I
resolved my technical difficulties.
No problem. I introduced myself because I figured, hey, you know what, I can do that until you come. And I sort of also was curious to see how many people had joined us last time for parts 1 and 2, or had watched them on YouTube, just so we know, because certain things, like I was talking about, certain things are foundational, like the fiduciary relationship, which you had so clearly outlined, and the role, right, you know, a lot of the relationship stuff. What I did also comment is that I feel, obviously we got certain very difficult questions this time, as always, kind of the questions where you're like, can there be another adult in the room who takes these questions, right? But then there were some questions that I just felt were going deeper. And I think that says a lot to what's happening on Instagram recently, is there is more conversation happening, not just about food and design, which both of which I absolutely love looking at when I need to park my brain, right, for the night. But I think it says something, the fact a lot of the questions were coming in are just going to a deeper space. And I think I'm very grateful for that. So I'm very grateful to the people who sent that in. Why don't we start with you introducing yourself, since I introduced myself.
So I'm Dr. Robyn Koslowitz. I am a clinical psychologist. Oh shoot, we have an echo. Let me just fix that.
We still have an echo?
One second, I'm gonna get rid of it in a second. Okay. Sometimes the echo is caused by by where my ring light is positioned. Okay. Okay, are we better? Do you still hear the echo?
I don't hear the echo ever. Whenever I'm on a live and there's an echo, I don't hear it, apparently.
If anyone was listening, if you hear the echo and it's disorienting, you let us know. So I am a clinical psychologist. I have a practice in New Jersey. I specialize in trauma and something I call post-traumatic parenting, which is all about giving our kids a normal, healthy childhood, even if ours was anything but. So I do a lot. I treat a lot of trauma. I tend to treat anything that's amenable to evidence-based treatment with a somewhat of a relational lens. Just to lower my volume, that will help. My own volume. Okay. So anything that's capable of being treated with a relational lens. I'm also going to shut my other phone. That sometimes helps. So I tend to treat a lot of OCD. I tend to do a lot of ACT, which is acceptance and commitment therapy. I tend to treat a lot of PTSD, acute stress disorder, complicated grief. I work with kids through young adults. Do a lot of parent management training where I work with the parent helping them with their kids. I supervise a few associates who work with little kids. I tend to more see parents and older kids at this point. But a lot of background in trauma and traumatic grief, which is, of course, our mutual interest. And post-traumatic parenting is all about giving our kids a healthy childhood, even if ours was anything but. That's my podcast. That's my community. We have a lot of followers here on Instagram who help inform me, inform each other, support each other as we understand this concept of parenting after trauma, which is something that has never really been explored in the professional literature. How difficult, or how complicated parenting can sometimes be after a childhood history of trauma. It's just not something that people are as familiar with as they are with other sequelae of trauma. Because even if you're healthy and you're doing well, and your PTSD is largely resolved, all it takes is having a baby for your trauma to open up in all sorts of ways you never anticipated.
100%. No, I so resonate with the podcast, every time there's a new episode and I find like a new angle and I'm learning so much from it. And I also appreciate the fact that many people on your podcasts are authors of different books and stuff like that. And I follow it up by reading some of those books, as well as, and we got actually a question about that, about your story time that you do also for both little humans and big humans. And I have a little human who likes to log on and make his comments, as you sometimes can see. And really learning a lot from what's out there. So I so appreciate that you're joining us. And I think that together we're really positioned, should I say, to try to do our best. I don't think we can possibly answer an anonymous Instagram question in a perfect way. And I think that's just my way of saying a disclaimer right here. If anything doesn't feel right to you about the way we answered, it's probably not right. Because if your gut is telling you that, you're probably right. You're the best judge of that. And you know the nuances of your situation. We're going on that
also the little nuance.
Yeah, we're going
the little nuance. Sorry, I don't mean to overtalk you, but the little nuance that you leave out because you want to stay confidential is probably the little nuance that we would have needed to answer you. And of course, it's my disclaimer too. Instagram isn't therapy. We're not here to do therapy. We're here to talk about therapy, which is not exactly the same thing. I'm sure everybody listening already knows that, but it bears repeating, right? Anything you hear on Instagram, anything you hear on Twitter or LinkedIn or wherever, or on, Google News, it might be educational. It's meant to be descriptive, not prescriptive. It's giving you ideas that you might take to your own therapist or your own counseling or your own journey, but it's not really meant to treat you. So even if it feels therapeutic, it's not actually therapy.
Right. Okay. Thank you. You said it so much better than I could. So let's get started. I created that Google Doc, which I know I did that at the last second, but I always take all your questions that came in into stories, and I try to subdivide them into topics. It also helps me see where there's any sort of overlap where we could possibly consolidate. We're not going to get through all the questions. We're going to try to get through as many as we can. So let's start with a bunch of general questions, because I think that's always a good place to start. What are some places or situations where therapy is not the answer? And I love that question.
Okay, so therapy, there's a few ways that therapy isn't the answer. Therapy isn't the answer if therapy isn't the answer yet. right? So sometimes a certain amount of processing and distance has to take place before someone's even ready to do therapy. Sometimes we're in coping mode, sometimes we're in survival mode, sometimes there are just much bigger crises that are demanding our attention right now, and therapy isn't the place. It isn't the time to start really unpacking everything that happened, right? If you were in a car accident and you're bleeding and, you know, the cops and the firemen are working on you to extract you from the vehicle and get you to the hospital, it's really not the time to talk to a therapist because you're going to be traumatized. When all of that part is dealt with, then the time to look for therapy, you know, that might be the time to look for therapy. But therapy, so sometimes it's not time for therapy yet. Right? Sometimes therapy isn't the answer because first other more practical things are the answer, right? So forget about even the survival things, but sometimes someone's treading water and just like reeling from a loss or reeling from a trauma, and we have to get ducks in a row. Like, you know, the family needs a place to live. If we have resources, we have to, like, think of Maslow's hierarchy of needs. We've got to have food, we've got to have clothing, we've got to have shelter, we've got to feel a sense of safety, meaning physical, sheltered safety, right? We got to deal with that stuff first before we're ready for therapy. Sometimes therapy is not the answer because you've tried a particular form of therapy, it's taken you as far as it can, you've gotten to a place, and there really is another place to get to, but you're not ready. You're not developmentally ready. Other stuff is going on in your life. You're not there yet. And then therapy is not the answer. And of course, sometimes therapy is not the answer because someone's not in need of therapy, right? They're not, you know, I get this phone call a lot. Sometimes schools will call me. I find schools are on, you know, two sides of the spectrum with this, where some schools will call me and be like, oh, you thought she needed therapy? Like, she witnessed her classmate die in front of her, and you think someone needs therapy for that? Where you're like, yeah, I kind of. And so she witnessed someone die in front of her, and then she's suddenly having panic attacks, and you're wondering if she might need therapy. I wonder why we're wondering, right? And then sometimes you have the other side where someone goes through something and the school is like, she must be in therapy right now, today, immediately. She doesn't want to go, but we're going to make her go anyway. And you're like, wait a minute. Maybe she's not ready, maybe not quite yet, and maybe she's not actually traumatized by it yet, or she hasn't come to the developmental stage where she has processed what has happened to her, where she's ready to get someone to help her reprocess it and understand it. So yeah, she may need therapy, but maybe not at age 8, maybe at age 11, right? She just may not be there yet.
Right. I think also we can't be predictors of the journey immediately. And I think everybody processes trauma differently. And that's why, you know, I'm very passionate about delayed grief, but I think a lot of delays can happen where, like you're saying, it may not be right now. So yeah. Right.
Right. And then there are some things that are not handled well with therapy. They're handled well with other modalities and things that are more,
give me an example.
Like, for example, first of all, sometimes you can have people who are going through something that's really more physical than emotional. And people think they need therapy. We have to focus on the physical needs first. Like, they're debilitated, they're sick, they're still, you know, panting, they're still like not okay. It's not the time for psychotherapy right now. Right? So there are situations like that. There are sometimes things that are better handled within the family unit and processed and discussed before it's time for therapy. It's not always that like therapy is best thing. Look, I have a bias that everybody could use some psychotherapy, that everybody could use sitting down with a therapist who can help them re-understand things that happen to them in their life. But not everyone can always use it right now at this particular moment, at this age, and at this stage, right? And sometimes it's a luxury. So we have to think, which luxury are we going for right now?
I think those were really good ways of putting it. And since you brought up the school thing, I'll bring up one question here that came up that was submitted by a teacher. A teacher said, as a teacher, I always get parents mad when I recommend therapy. How can I get them to listen without being defensive? And then it's interesting because after I posted that question in my stories, I got a follow-up from 2 different followers saying, why is the teacher making a recommendation at all? Why isn't this in the principal's domain? And then I got a teacher actually responding to this saying, yes, I think that we are overdoing it as teachers and overstepping our bounds by making a therapy recommendation. So I have a lot of thoughts on this, but I'm curious to hear from a clinical perspective, let's start with the first question. If a teacher is suggesting a therapy referral, and let's pretend in this particular situation, there's a legitimate concern going on in school. The teacher is noticing something in the classroom, whether it's socially or whether it's emotionally with the child's meltdowns or an inappropriate reaction to something, and feels, you know what, this child could benefit from some counseling. What's the best way to get a parent to hear that? Because I think naturally as parents, and I will speak only for myself as a parent, we can get very defensive about our children being anything less than perfect, even when we know they are not perfect. And I think that's a natural gut reaction of a parent.
So it definitely is, and it does take a very special and unique parent. I always am in awe, like in awe in general, of the parents who choose to send their kids into therapy, because it's a little bit threatening, right, to get someone else involved in your child's emotional life. I write an occasional comic called The Post-Traumatic Parent, which is all about what it's like to be a post-traumatic parent. You can find it on my Instagram page for people who aren't following me. And in there, I have one where a school calls and they say, you know, we need to talk about your son. He's having some trouble. And it says, like, what the school is saying, what the post-traumatic parent is hearing. And, you know, the school is saying your son is getting into some trouble. We need to come up with a plan. The parent is hearing, you're a bad mother, you're a bad mother, you're a bad mother, you're a bad mother. And, like, that's all she's hearing, right? So the point is to try to get people to hear what you're actually saying. And the best way I find to do that is by asking questions as opposed to making recommendations. So saying to the mother, and you're very good at this, right? Gaining consensus from people. Saying to the mother, you know, I'm really confused about the way your daughter reacts to this. I'm really concerned about the way your son seems to have a very extreme reaction to this issue that didn't seem so big. What do you make of it? And what's your plan for dealing with it? And having that conversation where we're both on the same team. And then if we're both on the same team, we both say, you know, neither of us, we're putting our heads together and we're not coming up with a solution. Maybe we together should be consulting with an expert who could then help us figure that out.
That's beautiful.
Because you're not coming and saying your kid needs therapy. You come in and say your kid needs therapy. Even me, right, I do this for a living, right? People come in and literally pay me to tell them what therapy their kid needs, right? I do a certain amount of diagnostic about, and that's what they want. I still don't do it that way, right? I still come from a place of, so these numbers would suggest your child should be totally capable of this, and yet your child doesn't seem to be performing that way. What sense can we together make of this, and who can help your child be what they're meant to be, right? It's so much more helpful in general to be collaborative. And going to the second and third part of the question in terms of like the principles and things like that, I think it does depend, you know, as someone who consults with school, I think it does depend on the organizational structure of the school, how the principal likes things done, what the culture of communicating with parents is. There are schools where it would be completely unthinkable and unacceptable for a teacher to say something to a parent without having ran it by the principal first. And there are schools where the principal would be surprised that the teacher would think to run it by her when clearly she has, you know, a recommendation to make. So that does depend on culture and things like that. Are there teachers who sometimes jump to a particular solution that worked for another kid without, you know, thinking it through, knowing the larger systemic pieces? Sure, that can happen. And then I would say to the teacher in that situation, you probably should always be bouncing these things by the principal, because she's more of an aggregator of information. She might know, you might teach the 5th grader, but she might know the 7th grader and the, you know, the 12th grader who used to be in the school, and the 5th grader and the 1st grader and the mother, and she might have much more insight, and she'll help you have this conversation with the mother. Like, don't be afraid, just like you're saying with the, like I'm saying to with the parents, you say to the principal, like, what do we do about this kid? How do we help this kid? Because this is seeming odd to me, or this is unusual in the way she interacts, or whatever.
Yeah, I think very well said. The piece that I can say as someone who deals with a lot of the schools is 2 things. Number one is, yes, it definitely depends on culture. And a lot of that culture also is, what's the communication like between the parent, the teacher and the principal. If there is any level of concern that the teacher will be judged for her own incompetence, same way as a parent feels judged in that sense of like, you are not a good enough parent if you have a child who's acting like this, which is completely baloney. If a teacher feels that way, she's probably less likely to approach the principal. But I will say also that, like you said, different schools run in different ways. I actually think the value for me sometimes in dealing with a teacher versus a principal on a case management level is that the teacher is actually seeing the child in the classroom. So the principal may sometimes have a good picture, and I think that's why it's really good for them, the two of them, to be working together, because the principal may have ideas about the home, about what it's like sibling patterns, like you're bringing up, and best way to communicate with this parent or stuff of that sort. Whereas the teacher may have the best insight on this child because Monday through Thursday, Monday through Friday, this child's in her classroom or his classroom doing whatever it is that they're doing that is concerning. So I kind of, if I ever have a situation where the principal says they're concerned, but the teacher says, I'm not seeing it. I'm not seeing it on the playground. I'm not seeing it anywhere. I would like to value a lot of what the teacher says, because I'm not saying there are always exceptions to the rule, but when somebody is living with a child for that many hours, 5 days a week, and doesn't see this problem playing out, I have to wonder if there's a bias based on a previous sibling or if there's something else going on that I need to wonder about. So that was just a great question. Okay, let's go to another.
This, by the way, I just want to interject about the teacher. Sometimes this is a very trauma history type of person, but sometimes if you're that teacher and you have your own trauma history, you're much more susceptible to shame. We, as people, I am a PTSD survivor, right? We are more susceptible to shame and to this feeling that we should know more than we do. We should be better at, what we do. So if you do have that kind of principal or that kind of parent is like, well, you should be able to interest him anyway, or you should figure out a way to get her to stop talking. I find the question how to be incredibly counter-shaming. So if you're afraid that the principal will come back to you and say well, why haven't you interested her in the lesson more? Why haven't you tried things? How? What should I try? How do I get her to pay attention to the lesson? What's your methodology? Give me a suggestion, right? Because what happens is simply learning how to use that how question, one of two things will happen. Either you'll get a great suggestion, be like, oh, that is great. I am going to try that, right? Or you get actually, come to think of it, yeah, I don't know a way to force a 16-year-old to listen when she doesn't want to. Okay, right? So I love just asking how.
I love that. Let's go to another general question, therapy question. When is it a good idea to use two therapists at once?
Interesting. I think I would have to, qualify that question as to, are the two therapists aware that they're both being worked with together?
Right.
Meaning it very often happens that you have someone who is in individual psychotherapy and couples therapy at the same time. It's pretty common. Usually the couples therapist and the individual therapist should know about each other and should be in communication. Not weekly, daily, whatever, but just a general, okay, so you're working on this aspect of the marriage, I'm working on that aspect of, the individual person, no problem. There are more and more approaches to therapy that have a skills component and a therapy component like DBT, right? Where you might go to a DBT skills group where you're learning certain emotion regulation skills and you're also seeing an individual therapist. But that's usually in the context of a DBT practice where that's how it's done. It's sort of sold to you that this is how it's done. More and more things are done this way where there is a skills component separate. For example, I treat OCD. I will sometimes work with an associate of mine where I'm doing the exposure and response prevention, the kind of all right, we're going to touch this germy object and we're going to do it. And then the other therapist is doing the talk therapy, the motivational stuff, the everything else going on in your life stuff, so that we're, bouncing off each other. But again, we're working collaboratively. And of course, there's a certain amount of bleed, right, between the two, but we both know about each other. I think I think
that's an important caveat is that obviously, if you want to hide one from the other, then I question what's really going on here. There must be something else. And again, by the way, with trauma, that could be just shame. Is that you're seeing somebody for couples therapy and you want your individual therapist to think you're doing great in your marriage. We could have different things like that going on. But I think that the transparency is probably key to the health here.
When you shouldn't do it is the minute you're keeping secrets from one or the other. that's when you have to examine why are you doing this, and you need to talk to one of them about this and have a conversation, because there's a risk for something called triangulation, where you kind of do this thing where, like, well, she says I could do it because I gave her this aspect of the story, and that therapist recommends I not do it, so she's the better therapist this week. It can get very, very murky very, very fast.
So let me go into something else. My therapist is talking boundaries, but it feels like so disrespectful to my parent. They want me to, this clinician is obviously helping her set boundaries with a parent. I did do a follow-up to this person who asked the question because I just wanted to understand a little bit of the situation. So it seems like there is a parent here from this client's description who has struggled with boundaries. And now this child is an adult, and those boundaries are really impeding different relationships in their lives, whether it's their relationship with their spouse or whatnot. And the therapist is trying to help her find her voice and be able to set certain boundaries with her parent, but it feels extremely disrespectful. And I will say that culturally, where this person's coming from, within the Orthodox Jewish community, there's a lot pinned on the respect between a parent and a child, and she's also afraid of the fallout of that, of what does that feel like, and from a religious standpoint, how am I handling all of this culturally?
Okay, so a couple of things about this. First of all, I just wrote an article, so for your Orthodox Jewish followers, I just wrote an article in Bina magazine, which is called The Fable of Mrs. McGillicuddy, which is all about explaining boundaries using the example of an old lady whose tomato garden is getting squashed by thoughtless people who keeps trampling through her tomatoes, and how eventually, I make it very poetic, and we have this whole story about how she starts with higher and higher and higher fences, and eventually she erects a giant brick wall, right? And the idea, and then of course all the neighbors are shocked. Like one day everything's fine, one day she erects this giant brick wall. What happened? Anyone who doesn't get Bina, after it comes out, I'm happy to send you a reprint. You can DM me. But that fable is a great way of thinking about boundaries. The goal of boundaries is not the brick wall, right? The goal of the boundaries is so that Mrs. McGillicuddy's prized tomatoes can be, protected, right? We all have those prized tomatoes, right? We all have those things that we care about that are important. The reason we have boundaries don't mediate distance. Boundaries mediate closeness. And everybody who has difficulty with boundaries doesn't get that. They hear boundaries, they hear distance. That's not what that is. Boundary literally means how close am I comfortable to getting before something feels super uncomfortable, right? And she wouldn't be in therapy and mediating this if boundaries had been comfortable and handled properly in the past. Inherently, boundaries are incredibly respectful. They're respectful to both sides of the relationship, right? The idea is how close can we be and still feel close, not stifled? How close can we be and still feel close and not feel like abraded, right? How close can we be and yet be able to give some feedback about, like, that doesn't feel comfortable to me? Inherently, that's a very respectful process, and it has to be communicated that way, especially to parents who don't get it in that way. The goal is closeness. The goal is respect. The goal is having a relationship where you're thrilled to see me and I'm thrilled to see you, where we make space for one another. That's the true goal of this. Now, it might feel uncomfortable because everything new is uncomfortable. Every new skill, there's going to be bumps and bruises because it's not so easy to learn a new skill. It may be helpful, like I do with any cultural group, talk to a religious or a cultural authority in your group. Like if I'm dealing with a Hispanic family, I'm gonna want them to talk to someone in their culture about how would you mediate this, right? Meaning, so if you're an Orthodox Jewish person and you are dealing with boundaries, you need to talk to a rabbi and find out what's the religious way of looking at this. It's not because that's therapy, but that helps you make sense of it in therapy, right? Sometimes that gives you metaphoric language. Sometimes that gives you a way of talking about it. So, very often it happened to me when I was in grad school, where I was working through cultures, and the first thing I did was call someone I personally knew in that culture and say, all right, how do we do this in your culture, right? Take me through what boundaries are like in an Asian culture. Take me through what boundaries are like in a Hispanic culture. And it's so much more helpful, right? Because the goal is not to be like, oh my gosh, I learned this new thing called therapy, and now I'm so smart and I have this whole new value system. Therapy is meant to enhance your ability to use your value system, whatever your value system is. It's not meant to say, like, oh, throw out your value system, like, that's over, right?
I think that's very important. It's interesting that you're referencing this because as you're saying this, I'm remembering I did a 3-day training, which I highly recommend for many clinicians on my thing in our house, Grief in California. One of the things that they do with you on either the last day or the second to last day was a very powerful experience. Each person had to bring in something that helps them through the grief process within their culture or their religion. And I remember we had a few women coming from a reservation, in a Native American reservation. And there was something outstanding about being able to learn how different their cultural norms were and how different what they experienced and how they experienced their walk through grief. And I thought it was very powerful for me. And I realized something, that I think our cultures and the way we do things carry such meaning, and we need to be cognizant of that. And it's important. And part of the reason it's so good to keep whoever your leader is within kind of, or whoever your advisor and mentor is within this loop. And sometimes it can be helpful, and I know that you've done this, if there's a release, to have a one-time conversation with this person so that they can kind of be on the same page, because sometimes people who've been through trauma don't know how to explain it in enough words. So they may come and say, you know, sometimes my mother gets moody and it's really hard for me, and my therapist is telling me that I shouldn't really go there for the holidays. And that sounds like, and I kind of feel bad because my mother's crying about this, and all of a sudden it sounds like, okay, you're an adult. Can you not tolerate a few minutes of moods in your mother and make her happy for the rest of the time? And sometimes the language is just stunted in the ability to explain what really is happening. And because there is so much nuance in that, having that cross conversation and then being able to then ask it from an informed point of view can also be a very big help.
And that, by the way, is one of those things about the fiduciary nature of therapy, where if you need to talk to someone, like you need to talk to someone's aunt or her rabbi or whatever, any religious figure, that person becomes what's called a collateral to therapy. And there's a contract. You can get it from whatever, if you're a mental health professional, from your state organization, where they sign it and they understand what their rights are, what their rights are not, right? What their expectations are, like meaning, I expect you to keep what's said in this room confidential, so we're going to talk about this person's case, but when you leave, you're not going to talk about it with other people because you're going to keep it confidential. And, you know, and also even explain to that collateral, like, you might start feeling some emotion about having this session. Here's where you can go with him, right? Like, so you're the aunt, you come in, you're giving us insight into the family structure, and now we've kind of opened that door. Maybe now you know what it's like to talk to a therapist, but I can't be your therapist, right? So like, to give them that sort of path towards, hey, maybe I should do therapy about this. I've never really processed this. So having that collateral contract and having that conversation with those collaterals about, this is what your roles are, this is what your roles are not, this is what information you're privy to, this is what you're not privy to. Let's all sign this paper, let's understand it, the patient as well, right? We're all sitting here and knowing this. And now we can have the conversation that we're going to be talking about. It's very, very helpful.
That's very important. Is therapy burnout a thing? I'm working through heavy trauma for 3 years and I want a break.
Yes, therapy burnout is definitely a thing. Therapy, I call it therapy fatigue, but yes, definitely. And I really question working straight on trauma and therapy for 3 years straight. Like, think about it as like PT, right? Where, as my physical therapist once told me, and it's so true, progress happens in the pauses, meaning, right, you can't rush healing to a certain extent. You are working way too hard in PT. You did every single thing I asked you to do. Now you need a 3-day weekend. Do not work out. Do not work out at all. Do not work out even slightly, right? Because the progress happens in the pauses. If you've done your work at the times you're supposed to do your work, the pauses are important. I'm not a big believer in 3 years of continual intensive psychotherapy. I'm sure there are cases in which it's warranted. I've never seen them, but I don't do very like psychoanalytic or psychodynamic work where like I'm really doing like intensive depth psychotherapy. Even when I did my own depth psychotherapy, though, it was time limited because I needed those breaks. Because there are times that it really makes sense to like go that deep, and there are times in my life where it's like, I go that deep, I'm going to injure myself in the same way that you run on a slightly twisted ankle, you're going to end up with a broken ankle, right? So I definitely, yeah, therapy fatigue's a thing. Therapy burnout's a thing. I think that you make a plan with your therapist. Either you make a plan to like not do anything deep for a while. If you want to preserve the relationship for other stuff, you could do that. Or you make the plan that you are taking a break from therapy for a while or trying a different form of psychotherapy for a while.
Right. I think that's a very good thing. Okay.
Yeah.
We're going to move through the next couple questions as quickly as we can because we want to get to as many as we can.
Okay.
The person, I'm going to read the question as the person says it. You know, there are some statements here that are this person's experience. So many unhealthy therapists out there. Do the pros of therapy outweigh the risks of damage and re-trauma? That's question one.
Okay.
Then she asks, how can I trust after being very seriously burnt from a licensed therapist? Okay, this is person number one. Person number two, and I consolidated a few questions here. Person number two says, how do I find a therapist who is good for you? That's, you know, kind of, I put it, and I think you'll understand why I connected the two. Person number three says, I've never had an unhealthy therapist. This was in response to her seeing the previous thing. I've had about 8 therapists over the years. I either changed because I moved or I felt accomplished to the max with this person and I needed to move on to another therapist, but always under good terms. How is it that people end up with unhealthy or toxic relationships? I'm genuinely curious. Is it a lack of research or is it something else? And then I got 2 messages from people just saying is that this resonated very much with them, both sides of the question. So I think let's talk about one thing from the get-go, and this was something that you very wisely said when we did parts 1 and 2. Obviously, we're dealing with questions here, and some of those questions are going to be about the problems in therapy. That does not mean that majority of the clinicians who are practicing therapy are the problems. And you know, you phrased it much better than I'm phrasing it now, but I think that's just important to say, not because I'm defending an industry. In the same way that I would say that I think it's unfair that many lawyers are targeted as money hungry and obnoxious and stuff like that. I've worked with many lawyers. In fact, we have an entire division of lawyers in Links called Legally Links who provide pro bono financial and legal advice to families on a constant basis out of the kindness of their hearts and nothing more. And they keep asking me if they can give more hours. So every industry will have its bad apples. And there's a reason why I try to interview clinicians. And I know that, I just want to say this, I know there are people who follow me who did not like a referral I gave, or worse, felt very hurt by it and felt that I am wrong about my judgment about this individual and that this individual is not a good clinician and has hurt them and has hurt other people. And I have to tell you that I appreciate the feedback and I take every piece of feedback very seriously. And we do our own internal research. Some of times what we figured out is that this clinician definitely has a pattern of not doing well, let's say with a person who struggles deeply with depression. This is just really not a good match. This clinician is really good for X, Y, and Z, but can be very hurtful and harmful when it comes to a person who's struggling with, say, a particular personality disorder, because there's just, they lack the ability to deal with that well. Right. Then there are clinicians who make errors in judgment that have happened. Right. And then there are clinicians who will violate a code of ethics, and that we have a very, very strong policy about. If that ever happens, that's an immediate reporting to the board and let the board do its own investigation. And thankfully, I don't encounter that often, but for the once or twice that I did have to do it, that's what a licensing board is for. So with that 100%. Having been said, I'll let you.
So first of all, I think that some of this has to do with the nature of journalism, even the nature of like DIY journalism, which is basically what Instagram is, right? Where everybody can like sort of post something that happened to their neighbor's cousin without doing any necessarily due diligence about what really happened in the story or things like that. A lot of times people ask me to comment on like ongoing stories that are happening like in the news. And I have a policy to never do that. Only because I don't think, I like to provide deep and thoughtful analysis of things. I'm not a surface level person by nature. And within the first 24 hours of something happening, we don't have deep and there's no deep and reasoned understanding of it, right? So there's a lot of times that people will, you know, tell a story, and then 3 days later, new information comes to light, and they don't go back necessarily and correct it, and people just sort of have the impression of the story. You know, I went into that store, the owner was entirely rude to me, or my sister went into the store, the owner was such a jerk to her. And then 3 days later, it comes out that the sister's, kid actually had, when she wasn't looking, I don't know, overturned his apple juice all over a display of expensive, I don't know what, merchandise, right? And the guy in the store was rightfully annoyed with her. No one's posting on Instagram the follow-up to the story, right, about how, well, turns out the kid had the flu and he was acting out of character and the owner was justified. So we sometimes form these snap judgments because we can do DIY journalism. And I think in journalism in general, there's that caveat that, man bites dog is, is exciting. Dog bites man is not exciting. So therapist behaving badly is kind of exciting, right? It's like, oh, this person must be a therapist and she behaves badly. There's certainly been a genre in novels, in popular press about that kind of thing. And we tend, the way our brains work is we tend to focus on the worst possible cases, right? And the real extreme things. That's why we feel safer in a car than on a plane, even though people tend to die in car crashes a lot more than they do in plane crashes, right? Because we don't focus on the salience of the risk when we're in a car. We focus on the salience of the risk when we're up in the sky and we're really far from Earth, right? So that's just the way our brains work. Our brains are sticky for bad, information, and they're Teflon for good information. So I think some of that is certainly the nature of journalism, right? But also, are there bad apples? Of course there are bad apples. In every field there are bad apples. This is why you need licensing boards. You need therapists who are members in good standing of their licensing board. You don't know how many times someone told me that they were harmed by a licensed therapist and it's somebody whose license had been suspended 10 years ago, or it's somebody who never bothered renewing their license. Kind of says something about you if you can't be bothered to renew your license, right? Or, and this is something that I've heard about recently quite a lot, people practicing under a much lower license and the demands of that much lower level of licensure, but referring to themselves at a much higher level of licensure. So for example, someone with a doctoral degree who never actually finished the clinical training for a doctorate in psychology, but is a substance abuse counselor, right? Which is a very, very low bar of entry. It's not that difficult. The barriers to entry to becoming a KSAC, a certified substance abuse specialist, is really low, really easy to do. So I've seen that where people refer to themselves as doctor because they do have a doctorate, but they're actually practicing under a much lower license, which means that, to me, that's already inherently deceptive business practice, and I'm really not happy about it, because if you're not practicing as a doctor, you shouldn't be calling yourself a doctor. So there is a certain amount of that kind of thing going on where, yeah, the person is technically licensed, but are they licensed to do what they're doing? Not entirely sure. That being said, I think that a healthy therapist will accept a certain amount of challenges, like, why are we doing this? Help me understand. Will be okay talking to someone who wants to give a second opinion. Will be okay with a patient saying something like, I think we've gone as far with this form of therapy as we can. I'd like to try a different form of psychotherapy. Like, I've done, talk therapy. I'd like to try somatic work for a while. You're not a somatic practitioner. Who can you refer me to? A healthy therapist is not going to be offended. A healthy therapist is going to be like, oh, that's good. You've gone as far as you can, kind of like going from elementary school to high school, or, going on to the next stage of something. And that's totally okay. If your therapist is not okay with that and not transparent as to why, meaning, so sometimes someone will say to me, I think I've gone as far in therapy as I can. And I said, and I'll say something back like, except we haven't talked about the whole part about X, Y, Z. So I really don't think you have. We need to talk about X, Y, Z that we haven't talked about yet. Are you ready? Right? Like, then, I'm being transparent why I don't think you're ready to leave therapy. Right? So that's important. If the therapist will not be transparent about it, won't talk to someone and give them a second opinion as to why, consult with someone else as to why. Of course, there's a certain amount. I mean, I've certainly had the people who, every time I made a recommendation, they wanted me to talk to 6 cousins and 17 aunts and 15 uncles and 12, neighbors about, why I'm making that recommendation. There, I'm going to set a certain limit. Like, I'll talk to one person who you greatly respect, but I'm not talking to 17. Right? It's not healthy for you, and it's not going to be productive for our therapy, right? But if your therapist is not going to be transparent why they're doing the things they're doing, only in 1 or 2 examples I can think where transparency isn't the best idea. Like sometimes you don't quite tell someone something you perceive about them yet because too much truth is uncomfortable. So you sort of say half the truth. That's okay as long as there's a plan for transparency at some point, right? But that being said, I do think that we pay a little too much attention to that idea of like the bad therapist. There are therapists who are bad for a situation, but most therapists, humans don't like to fail. So most therapists who know that they're not cut out for a certain situation are pretty good at saying, this is not for me. Like I know the things I don't treat, and I don't treat them. And it's because
I want to interrupt and say something, and maybe because it's just happened to me recently with the referral that I made, where initially the client presented to me and to the clinician as one issue being the presenting problem. It's only about 6 months into the therapy that the presenting problem is something completely different and completely out of the therapist's league. And not only out of the therapist's league, it's something the therapist really does not like to treat for whatever reason. It's something that they don't treat. And had they known that from the get-go, that would have been something I don't treat. So for instance, if let's say substance abuse was something that really is ongoing, and let's say this therapist says, I don't do substance abuse. I'm not trained in it. I don't do it. I don't do the whole thing, right? But this person came in really as insomnia and anxiety, and that's really something I do a lot of. And only in the honesty and the development of that good relationship, 3, 4, 5, 6 months in, does the client admit, well, by the way, part of the reason that I realize all this anxiety and the insomnia spikes is kind of when I take my substances a couple of days before. Right. And I'm very careful not to take them in the 48 hours before I see you because I don't want it to pop up that way, right?
Right.
At that point, what I've seen happen, and obviously I'm changing a lot of the details, what I've seen happen is a tremendous rupture. First of all, there's the therapist's own feelings sometimes of like, I'm letting this client down, but there is no way I can continue to treat this client because A, there wasn't honesty, and B, I don't do this. This is exactly what I list as the things I don't do. And there does need to sometimes be a termination, which we'll talk about in a moment, and the client is left feeling really angry that the person I finally connected with, even if, and I will say in this therapist's defense, this therapist recommended a great program and gave a referral about a place. This is what they do. They do substance abuse. I don't do substance abuse.
And this is the messiness of treating real humans, right? Where sometimes something comes up and you're like, well, that's actually a substance use disorder or something. I know, like, for example, I don't treat eating disorders. I will treat people who have some disordered eating, but not if it's like a full-blown anorexia, binge eating disorder, bulimia, where it's like that's the primary reason they're in therapy. Mm-hmm. Once or twice it has happened that someone has, you know, slowly but surely brought up more and more, and I realized, oh, we're not just dealing with disordered eating, we're actually dealing with a full-on eating disorder. Now, then it becomes very much up to the therapist's judgment, and that's going to happen. I hope every therapist should be in supervision. That's going to happen with either peer supervision or formal supervision, where you're going to have a conversation. I remember in one particular case where I was treating somebody that I don't normally treat. I was in a peer supervision group, and my peers all pushed me to keep it because they felt I was doing good therapeutic work there, and they felt I could. So I said, okay, the only way I'm going to be comfortable doing this is I need to hire a supervisor who specializes, let's say it was eating disorders, who specializes in eating disorders. And that's what I did. So I hired a supervisor who literally treats nothing but eating disorders 24/7. And I went to her for ongoing supervision, obviously with discussing it with the patient, right? And then I was willing to continue with the case. But there came a point in that case where, which very often happens, it's due to actually good therapeutic work, that the eating disorder really reached a breaking point, and I ended up referring that patient to that person who had been supervising me on the case to treat her solely for a while. I think she was working with a residential program, maybe it was an IOP, an intensive outpatient program, but for a while she saw that person because the case kind of like progressed to that level, right? So yeah, there were some emotions about that, both for me and for the patient. But the more transparency there is about, I don't do eating disorders, but I do work with you. Let's see where this goes. Just so you know, I'm going to be seeing this person who's going to supervise me on your case because there's probably things about eating disorders I don't know. I only know what a generalist knows. I'm not a specialist in that area. There are things I'm a specialist in, right, where I could supervise someone else, like trauma or OCD, where I could be like, okay, I know the ins and outs of this field. I can hear OCD thinking that sounds like something else. I can hear PTSD that's been long buried, or delayed grief that's been long buried. I can hear it because I'm so attuned to it, because it's what I specialize in. Eating disorders, there's probably things that are going to go right over my head. And this therapist can be like, oh, you know why she's saying that, because she plans on doing X, Y, Z. And like, you need someone who knows that world. These types of things happen when we're doing real therapy with real humans. Yeah, it hurts, but a lot of the things that help us hurt us sometimes in the short run, right? Think of physical therapy. It hurts us in order to help us. The goal, though, is what's the therapist kind of, plan in this situation? What's the goal? At what level will I say this is too much and it's not something I do, or I'm scared for your safety, and if I'm scared for your safety, I won't be sleeping that night.
Which, by the way, answers a different question, which we're not going to have time to go into, but somebody was also angry at her therapist for terminating when she said her therapist told her after she ended up in the hospital twice for attempts to suicide in a span of whatever it was, a short amount of time. She said, that's it, we're done with working together, and also referred her onwards. Part of that is because therapists genuinely will care about the life of a client or a patient that they're working with. And if they don't feel they can do responsible therapy with you in the state that you're in, I know it's horrible to hear it, but at the end of the day, they really want you to have the best level of care, and they are not the best level of care.
Right. Think of it this way. It's not a rejection of you. It's a rejection of your lack of safety. And the fact is, this is something we don't like to talk about as therapists a lot, but in my peer supervision group, I had a colleague who lost a patient to suicide. And it was devastating for that therapist. It was such a loss, and it had to be processed so hard, even though on objective measures she had done nothing wrong. It was so painful. It was painful for all of us in the group. It was a sheer trauma that we all had to process. It was really hard. And the fact is that therapist had to take a leave of absence from treating anybody. So if concern about one patient means the whole system breaks down and all the patients can't be treated, that's a pretty important consideration, right? If the therapist is not able to do self-care and not able to manage her own anxiety about a patient, and therefore impacts all the other patients, then nobody benefits, right? So therapists get cautious about these things, not just because there's some like novel where some therapists got sued and it's all about that, not just because of that, although that's a consideration, therapists are people, but also because of the consideration that therapists go into this field because they genuinely care about people. And losing someone you were trying to help that you genuinely care about is really devastating. So you have to know it from that perspective. The therapist did not reject you, right? When she said, this level of care is too high for me, you need an inpatient unit, the therapist rejected the possibility that you would harm you because she cares about you so much.
Right. Wow. Okay, let's move on to modalities. And we're going to move through these pretty quickly because I don't think we're going to go into the textbook kind of things that can explain a lot of these modalities, but I think people ask good questions. Which modality of therapy is good for PTSD? I love the question.
Okay,
Can I just tell you my answer for a second, off the cuff? If somebody ever calls my office for a referral and starts with the fact that they want to know which modality is good for grief, for loss, for trauma, for anything of that sort, I don't answer the question. Because I think that, like, going back to a lot of the times our conversations is we treat people, and those people may have different struggles, but it's not about the modality being applied to every Tom, Dick, and Harry out there. It's part of the therapist's toolbox. They will use modalities, obviously, that they were trained in, but I don't ever refer to a clinician solely based on modality. Sometimes modalities tell me about the type of personality that a therapist has and the type of structure to their practice, which may be a good fit for a person of this personality and this structure. But off the cuff, when somebody says that to me, what kind of therapy would be good for PTSD? I don't know what kind of trauma. I don't know your personality. I don't know what has or hasn't worked for you in the past. I don't know what fears you have around this. I don't think it would be fair to name any kind of therapy. Feel free to disagree.
I agree with you, and it's a very, very hard question to answer for that reason, because it's not like a physical disease where it's like this form of antibiotic does not work on this form of disease. Or, you know, you go to a doctor sometimes and you want antibiotics, the doctor's like, no, this is a virus and antibiotic won't help, right?
You're like, give me antibiotics anyway.
Right, that kind of thing, because you're using, right, it's very textbook and open and shut. If you look at something called common factors research, which means if someone looks at all the different forms of therapy in the world for something like PTSD, or a great many of them, and they boil down what works, what comes out is retelling and reprocessing of your story to a compassionate witness. The question is, how do you get to the place where you're retelling, reprocessing your story to a compassionate witness? And the only modality that still is very effective but is separate from that is thematic psychotherapy, where you're re-experiencing your story through your body in the presence of a compassionate witness. So that's slightly different. But on the whole, how are you going to get there, right? There's a lot of road, like, you know, the saying, there's many roads to Jericho, right? There's a lot of road, right? So you might get there with EMDR, you might get there with traditional talk therapy, you might get there with trauma-focused cognitive behavioral therapy, right? There's a lot of different approaches, but the there that you're trying to get to is, you know, retelling and reprocessing your story with the aid of a compassionate witness. I hesitate, I worry about talking about modalities too much, only because there's such a push now to have not like non-licensed, you know, paraprofessionals who like say they know something, like they know EMDR. I've seen recently like an EMDR coach where like they know a technique, they're a technician of a technique. Now, under the supervision of a licensed person, that sometimes is very useful and helpful. Like there are, you know, substance abuse places that have hypnotherapists that do a certain portion of the treatment under a much larger umbrella. That's okay. Someone who's only going to do hypnotherapy with no background in mental health, no background in counseling, no training in psychology, it worries me. So when people tell me they're an ACT coach, acceptance and commitment therapy coach, or an EMDR coach, or an EFT coach, emotional freedom technique coach, I worry, because that's not how mental health works. It's not like take this penicillin and call me back in 2 weeks. Just not the way it works.
Right.
But
and I think that leads us to the next question that somebody asked, is that there's this whole movement out there on people calling themselves trauma therapists. What's the difference between a trauma therapist and a regular therapist? I'm going to tell you where it's coming to me. Just this week alone, 3 of the phone calls that came in were from helpful family members or school personnel or whatever who are involved in a case. And they said to me, you know, I think she has to move from this therapist to a trauma therapist. And I genuinely was confused. I'll be honest with you. I was completely confused. The reason I was confused is because I knew this child's trauma or this teen's trauma. And the therapist who I referred them to is not just, let's say, EMDR, you know, informed, but completely trained and certified, or not just somatic psychotherapy, just took a 3-day course, but they are a good licensed clinician with 8 to 10 years of experience who also is certified in a 3-year institute. So I was like, literally, I was like this, and I'm not usually like this. And I said, just clarify for me for a second. Is there something you know that I don't know? Because this person is seriously certified in many different trauma modalities. Like, what about, and they were stuck just as much as I was stuck. And I just realized exactly what this person's saying is there's a new lingo out there of like, I need a trauma therapist. What's the difference between that and a therapist who is certified in and trained in dealing with trauma?
So a real trauma therapist, someone who actually is entitled to that title, is someone who has completed, I would say, postgraduate studies of some sort. And I mean completed, not just taken, in trauma research studies of one form or another. So like, for example, that's what Daniel Koch works with the Trauma Research Foundation, right? It's a very well-known postdoc, right? There's a lot of trauma research institutes, trauma initiatives. There's EMDRIA, the EMDR Institute, right? You've completed your certification in an aspect of trauma, and hopefully you've done more than one. Like I've done, a lot of the Bethel Van Koch stuff, although I never completed my doctorate because COVID. So I'm restarting. They were very kind to me, and they said you can complete your postdoc with us, even though I completed 3/4 of it. You can restart with the new cohort and finish the ones you didn't finish, and then graduate with that cohort, because we get it, COVID, right? Okay. So, right, so someone who's done that, I've already done like the TFC-VT one, I've already done the EMDR one, right? So someone who's got experience with a multitude of modalities, or is a real expert in one modality, but like that's what they do, that's where they hang their hat. They have postdocs in it, or they have postgraduate certificates in it, and they like somatic experiencing, for example, someone who's done it for a long time, has all the certifications, and that's their modality. That's great. There is something called trauma coaching, which is different. The whole premise of trauma coaching is something that I have a lot of questions about, because if you look at people who call themselves certified trauma coaches, they will say things like, I help people move past their trauma. I don't believe we can move past our trauma, so I find that a little bit like, how would you do that? I think you move forward with your trauma. I think you integrate your trauma into your current self and into your values, but we don't move past our trauma because the person's still dead, right? The car accident still happened. So how do we move past that, right? So I'm a little, confused about that lingo. Anyone who is talking a little too much about like the post-traumatic growth outside of the context of just how hard that journey is, and has that whole rah-rah can-do, attitude about like, just don't think about it and you're past it now. I wonder how truly trauma-informed they are. Just because they took a 3-day course in trauma coaching doesn't make someone a trauma specialist, but that's the kind of thing where you question and you ask. So for me, if you're a trauma specialist, you've done one of two things. Either you've really, 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 really honed your skill in one area of trauma therapy, but you're like a true expert. Like you're a DBT therapist who's like done training, at Marshall Linehan's Institute. Like, your stuff, you're certified, you've been doing this for years. You finished EMDRIA and you're a consultant, you're something like that. Or you've done a few postgraduate certificates in a few places, but like a full 2-year certificate with study groups and supervision, right? And like, so you're conversant with a multitude of therapy options for trauma, where you're like, yeah, I've done this for a long time under supervision, not just a 3-day training or a really cool book. I know what I'm talking about. Because, yeah, anybody can say, hey, I'm a trauma expert.
Right. No, I think that's a very good point. Let's go through the last two modalities, and then we're going to move on to something else. One is, my therapist recommended I join a DBT group. Does that mean she thinks I have borderline personality disorder? And what was fascinating was I put up the question. I always like just sharing the questions because I think it's great. And I had 2 people message me right away. They were like, absolutely not. I'm in a DBT group for something totally different. Or another person writing to me, she goes, I actually want to go into DBT because I want to learn how to feel more, and it's going to help me connect with my emotions more. And I'm like, wow, just look at that. So if you had like 60 seconds, what do you think is going on here?
Well, I think that maybe the therapist is hinting to you that you have borderline personality disorder, but most therapists are pretty good at saying straight out, you have borderline personality disorder, right? Because that's how you tell someone they have borderline personality disorder. DBT skills are useful in so many forms of therapy. It's one of those things that, when I learned DBT skills in order to teach them, they positively impacted my own life because it is just so cool and so well done. A really good DBT group is fantastic. So no, I don't necessarily think that. Now, is there an off chance that your therapist is somehow roundaboutly hinting that maybe you're borderline? Perhaps, but then your therapist maybe need either one of two things. Either you're really scary to communicate potentially upsetting information to, in which case that's a focus for psychotherapy, and you possibly do have borderline personality disorder, and no problem, deal with it, focus on it, get treated for it. It's, DBT can help turn borderline personality disorder into a superpower. It's not necessarily a bad label, right? Or you're feeling very, very, very criticized and shamed and blamed for your own emotional needs in your family of origin, in your life, and your emotional skin is a little thin. And again, DBT therapy will be very helpful for that.
Right. Okay. So many questions. My gosh, we're not even getting close. Okay. Let's go through. Let me just decide if we're going to do just a few. Okay. What happens if one doesn't go? Let's go to some of the lost questions. What happens if one does not go to therapy after losing a daughter? And somebody sent literally the same question about what happens if one doesn't send one's child to therapy after losing a parent. So I just want to say for a second is that I get a lot of times, and I know that you get this also, right after a tragedy or something like that, everybody needs therapy, an emergency right now, they need therapy. I think what you said in the beginning about not yet, in some of the cases it's not at all, and in some of the cases it's not yet. When I say not at all, I'm going to speak from the grief perspective of the parental grief. Grief is normal. Actually, a person who is missing and sad and grieving a parent is normal. There is nothing about that that requires therapy. So if you call me up and say there's a kid who just lost a father, she's 7 years old and she's really sad and it's 6 weeks later, I will clap and sing and dance and tell you that is so normal. Be that supportive friend, neighbor, aunt, cousin, and just listen. And there's a great set of books by Alan Wolfelt, called Companioning Through Grief. It just tells you literally how to walk beside, not in front of, not guiding them, not behind them because you're afraid of them, but literally beside a person who is grieving and just be there. That process is gorgeous. That process is what literally takes a person through grief in the healthiest form. The three places where I find usually I end up doing the referrals in terms of grief is either the cause of death was something very traumatic or sudden. That could be either from a suicide or overdose. That could be from a sudden car accident. That could be from a sudden heart attack. Or that could also be where somebody was not informed that person was sick, and from one second to the next, the person died, and there was this whole distrust and secrets and all that stuff going on. That's one place. The other is if there was a complicated relationship with the person who died, right? If that person either was just by nature just somebody that you butted heads with, or if that was somebody who was abusive on the other end of the spectrum, right? There's going to be a lot to process over there. And in case of parental loss, I also say that let's look at what the relationship is like with the surviving parent. What was it like before and what is it like now? If all categories, if we're going to say the death was done well, right? If it was a good hospice plan, it was a good closure, and, you know, as good as it could be, it was done well. And it was a great relationship with the person who died, and all closures were done. And there's a great relationship with the surviving parent, frankly, then unless we're like past quite a bit of time, I'd say for sure I want to look at 9 to 12 months. Before that, moods, anxiety, a little bit of sadness, crying spells every once in a blue moon when you walk into your favorite card store and you see a card that your dad would have loved, all normal. That's not what, that doesn't need therapy. What we're looking at most of the time is a problem in one of those three places. That's my general take.
I think that the way it works is, yes, humans have a capacity to heal. Humans have a capacity to heal themselves. If somebody's healing and you see that spiral upward from very sad to sad but contemplative, right? They've gone through their stages of grief and they're moving in the right direction, then we're fine. It's when we're sort of not fine, like there's a sudden change in behavior, and I don't mean something like, you know, now I understand the meaning of life and I'm more contemplative. I mean a sudden change like I don't drive cars anymore because my father died in a car accident kind of thing, right? Where there's a sudden change and it's disruptive to that person's life. I like to use this thing called the differ scale, which is this idea is like, how disruptive is this? What's the duration like? What's the intensity like? What's the frequency like? What's the impact on the family? What's the impact on education when we're talking about a kid? What's the impact on relationships, right? If there's normal impacts, her friends are a little shy around her since she lost her father, okay. If it's like she's completely cut anyone out of her life who reminds her of her loss, all right. So now we know, because this person is not spiraling upward in a healthy manner, they're sort of getting stuck on a different trajectory. I think in literature, the example is, you know, Miss Havisham in Great Expectations, who like lived in her bridal gown after being jilted at the altar, and she died, an elderly woman, alone in her manor in her bridal gown, right? Where you're stuck in a certain developmental stage, you can't move on. So what's the effect of not doing therapy? Maybe nothing. Maybe the normal healing will proceed apace, and maybe someone's going to get stuck in something. And so often it happens with my podcast. One of the things I like to do is I ask people to ask me for topics and authors and things for future episodes. Like, what do they want to know? So many people have made points or asked questions or said something, and then they're like, oh my gosh, I'm totally stuck about that. Like the question, I'm about to record a solo episode about what to do if you have a flashback in front of your kids, because someone in my community mentioned as like a throwaway that she never takes her kids to places where there are big crowds and loud noises, because what if she has a flashback? She had been in a bombing, and what if she has a flashback? Like what if she's in a mall and there's a loud boom and she has a flashback and her kids will be terrified? And it never occurred to her that she's shaping her entire life around her trauma until she asks the question, wow. Right? So you don't know sometimes that you're shaping your life around avoiding something. Oh, I'm not driving. It's just I just like to walk really far all the time, even in 0-degree weather, right? Where it's like, wait a minute, maybe you're shaping your life around the trauma and we need to do something about that. I think most people, if they're intellectually honest, or if they ask for feedback of friends and relatives who truly care about them, they'll get the answer about that.
Right.
Especially adults.
Right. And I noticed that there were a few follow-up questions. I'm so sorry we're flying through the ones that we got, and we'll try to get through it. Okay, I lost my father when I was 9. I'm a married woman now, and I want to do therapy with a male therapist. My husband is not comfortable. He is afraid that I will emotionally connect with this male therapist. What are your thoughts?
So I have a lot of questions about the desire for a male therapist. Meaning, is this some sort of a fantasy wish fulfillment where I'll have a sensation of fathering, and that's why I want this therapist? In which case, you're ultimately going to be disappointed, because your therapist will do many things, but he's not going to be your father. So this is something I think you need to strongly explore within yourself, perhaps with your husband, perhaps with somebody who knows you both, like a marriage counselor, and think through very hard. And then there probably need to be a lot of checks and balances. If you decide to see a male therapist, for example, let's say you heard someone speak and they're an expert on grief and you think they totally would get you, you would have to set a lot of checks and balances around that relationship, because things that start out in one dimension, like a fatherly feeling, can turn into another feeling very, very, very quickly. So there would need to be a lot of checks and balances around it. By the way, you can also experiencing a sensation of fathering in therapy with a therapist of either gender. Fathering is just the process of sort of being tough on someone. Mothering is sort of the process of being nurturing with someone. A male therapist can be nurturing. A female therapist can be tough, right? So if it's the experience of fathering you're looking for, then you have to think very hard why and what the function would be and where you're going with that.
Fascinating.
Because it's not clear from her question if she means a particular male therapist that right. She really likes and thinks would be helpful to her. So I'm not sure.
Right, okay. Question. This one I have a lot to say about. I'm single and dating a widower with kids 2 to 14. Any tips? I can't have my own kids and I want a family. Okay. So full disclosure, Dr. Koslowitz and I both attend the weekend that I run for Links. At that weekend, we get to hear from a lot of kids whose parents have remarried. Some of those kids, by the way, have great experiences. Don't think they all come in with negative experiences. Some of them actually, between you and me, I'd love to interview their step-parent who is doing a marvelous job. Even with the things that they don't like, I'm like cheering, like, yay, you're doing this right. And then, of course, there are a lot of stories where I'm just sitting there scratching my head and wondering how in the world did this marriage even happen, and how in the world is this ever going to last? Now, I have a few statistics that I can share. I am not a researcher. I am actually, as I introduced myself at the beginning, not a licensed mental health professional, and I'm certainly not a licensed researcher. But what I did was a little bit quite formal research, shall we say. We interviewed 60 men and women who had remarried from different parts of our Orthodox Jewish community, some of whom had stayed married in their second marriage, some of whom had divorced, and we asked them the identical question. What do you wish someone had told you before? And we figured, let's see what we can learn. And I wasn't prepared for what happened. I had this like Google sheet or Excel sheet, this was several years ago, that I was typing the answers in. And all of a sudden one night I'm reviewing some of the responses and I'm like, this is really weird. They're repetitive. And these are people who are 60 or 30 living here with a lot of children and a large family, someone who's already had all their children moving out, and we're getting the same things again and again. So we actually distilled it, and we pretty much came up with about 4 things that we have seen as sort of the pieces that have made for effective long-term relationships. Okay, and I'll get to that in a second. But what was fascinating to me is that when we started applying it in terms of meeting with people as they're dating, or at worst case scenario when they're engaged, and even when we share these things, right, it goes to here. And then suddenly when these couples are immersed in the actual life of being a step parent and stuff of that sort, all of a sudden what we said, it takes on a new light. So if you're here and you're the one who's dating, you're going to hear some of what I'm going to say, but it may not make as much sense to you as it will if you actually marry this guy. So I think you'll find this fascinating. I don't know if I ever shared this with you, but one of them was, don't bring a crisis into a crisis. And if I could bring this, it's the best example that I give people. It's, you don't have a new baby. You don't try to have another baby in a bad marriage, because it never makes it better. So sometimes people say, like, bringing in a new person into this family, a new mother, a new father, a new wife, a new husband, is such a beautiful thing. It may be the most beautiful thing, just as beautiful as a new baby is, but it's still something that shapes.
The Brady Bunch was primarily fiction, right?
So basically what happens here is that when you're trying to fix anything in the home, so what, if I'm giving you advice as the person who's dating, you need to find out what the expectations of your role are going to be. If these children are between 2 and 14, is he looking for a wife? Is he looking for a mother? Or is he looking for a housekeeper? Or frankly, a combination of some of those, but what's the primary wish here for bringing you in? Is it for companionship, right? What's really happening here? Because essentially the best people who are poised for the best remarriage case scenario in our very informal research are those who don't really need to get remarried. They've got life under control. Their home is well maintained. Their children are essentially taken care of in the best way possible. They are emotionally living a rich social life, and financially they're doing the best they can, and they're in a good work environment or whatever environment. They're okay. And frankly, this would only enrich their lives to bring someone new in versus fill a void.
Right.
If he's got children 2 to 14, and the expectation is that he's essentially marrying you to be the mother, you may have a disappointment that you're looking for a husband and he was looking for a mother. And that's where the clash begins, okay? So that's...
And the children may not be looking for a mother, so that's also...
That we're going to get into the kids in a second, but let's talk about this relationship. The other piece that we saw a lot was the need, they all, and this was across the board fascinating, felt they quit therapy too soon.
Yep.
Our recommendation is that a couple who's getting remarried, you know, let's say you were in whatever your life circumstances were and he was widowed, and let's say you were each in individual therapy. Don't go to the other one's therapist for couple therapy. That's like a really bad idea. You can go in for a collateral session, 2, 3, that's okay. But that shouldn't be your primary couples therapist. 2 things. Number 1 is it wouldn't be fair to destroy that relationship. And number 2 is you're never going to be able to buy in. Oh yeah, well that's because it's his therapist. He's on his side or something of that sort. You need somebody neutral. Finding that couples therapist is a really good idea within the dating stage. Because that couples therapist,
if you don't have that, you're in a lot of trouble.
Yes, and that couples therapist can help facilitate
prior to the marriage.
Right, and that couples therapist can help facilitate a lot of the hard questions that you may be uncomfortable to ask on your own, but may be troubling you within there, and help you both ask each other these questions, like what's going on for you and what do you envision as my role, can sometimes be a little uncomfortable to ask when you're in this place, but it's completely normal therapy conversation, right? And that's where you may discover maybe it is right for you, maybe it's not a good fit, right? Following through with that therapy after marriage is essential, particularly since the first month or 2 tend to be honeymoons. Everybody's happy. The kids are in love with her. The kids are in love with him. Everybody's so happy. Everything's wonderful. That's when couples oftentimes quit therapy. Sometimes not so soon. They'll quit 6 months in, 10 months in. I'm going to give you something that may not be fair of me to say, but I will say it as an advocate for children. So long as those children are living in your house, you should be in therapy as a couple for 2 reasons. Number 1 is that having a space once a week for an hour to talk things through is really, really good as a couple who's dealing with this kind of dynamic. It's good for many couples, but it's certainly good for a couple that's dealing with this dynamic. Number two is neither of you will ever be able to be objective on his children. I know in this case, you're not coming in with your own. You will not be able to be objective about his children, their behaviors, and what's going on for them. He can't be objective about his children because, hey, they're his kids. And we just talked about parents being very defensive about their kids. So behaviors won't be naturally something you two can work through from a healthy, wholesome place without really a third party in there. So that was the second piece. Third piece, cannot stress this enough, is the importance of a financial prenup. And if you are getting married later in life, I will say that one of my mentors in this field said to me years ago, also a healthcare proxy and a healthcare prenup.
Yeah.
Because sometimes people get into a new marriage in their 70s. I'm not saying this can't happen in their 30s. And 3 months later, he or she has a stroke and the children are out of bounds of making decisions based on state laws for their parents' care, but may know what their parent wants. You need to decide that before. The person who actually shared that with me had recently passed away and wound up being married to their second spouse for like 27 years. And of course, their spouse made all the healthcare decisions at the end and was respected by the children because it ended up being a beautiful remarriage. But they weren't stupid, either one of them in the beginning, saying we're older and we're past retirement stage and we want to take this into consideration. The fourth thing is, and this is, different culturally, but if you're part of any religious community, you want to make sure that you have an agreed upon mentor before, or rabbi, or whatever your religious leader is. And the reason is because a lot of times we will come with different values into a second marriage than we did first time round. First time round may have been more similarity, two young college grads, two young people, period, very similar. In a second marriage, there tends to be a lot of differences. Culturally within the Orthodox Jewish world, it's very rare at a young age for somebody who comes from Middle Eastern countries, what we call the Sephardic culture, to be marrying into somebody who comes from like Eastern European culture. But this is completely normal in a second marriage because we tend to look away at a lot of different things.
Right.
That could be a real problem because especially when you're raising two different families with two different cultural values, whose cultural values dominate the home. And this is extremely important. I have a friend of mine actually in the professional field, in the grief training field, who is from a Hispanic culture, and she just got married in her second marriage now to somebody who's seriously Irish. And you have no idea how much learning both of them are doing about what their kids have as expectations of family values, of what roles grandparents play, and this whole thing, and it's something to navigate. So my advice to you, if you are dating him, is really get into therapy and get into understanding what your role is going to be, and understand from the children's point of view, and I'll let you take this piece, the kids aren't being asked for the most part. They're not.
And even if the kids consent, keep in mind that they haven't reached the age of consent yet. So what you might consent to at 8, you might rescind your consent to at 16. Now, my big question would be, if you can't have your own children and you're hoping to be these children's mother, and maybe both you and the guy you're dating both feel that you're primarily looking for a mother for the children, so you think you're on the same page for that, remember that there are also children here. My big caution would be, and I had this conversation with a friend of mine who was contemplating marrying late in life someone who was a widower who had a lot of kids, was, are you aware just how much the entire function of the female adolescent of the species is to make the adolescent female of the species want to jump over a bridge? Like that's the actual function of adolescence, right? Now, when you share a genetic code with someone, some of that is smoothed over simply because sometimes you sort of get the way their brain works. Even when you want to strangle them, you get the way their brain works, right? And I'm using very strong language like jump off a bridge and strangle because that's what it feels like to parent a teenager, especially the same gender teenager. So you're going to marry this kid, you're going to marry this kid's father, and this kid maybe at age 8 really consented, and you're like, yeah, I get to be someone's mommy. Then at age 16, she would have done the same thing to her biological mother, but she doesn't want a mommy because I'm 16 and female adults are the enemy, right? So then what? Then what happens? How are you going to feel about that? right? What are your emotions going to be around that? Do you have your own therapy and enough strong sense of self that you're going to be okay with how that goes? Are you in couples therapy? So inevitably when you and your husband disagree, and maybe you feel you have more insight because you're female, maybe your husband feels like he has more insight because he's a biological parent, maybe there's some injunction from the biological mom that you feel must be carried like a certain way of being raised or whatever that isn't holding up to reality. All of that is something, those hard conversations and questions can be had in the presence of a compassionate witness who is much more even-handed because they simply aren't related, right? And they have perspective because they've been doing this with you for a long time. So it's not like we're going to say, no, don't do it, right? No one's going to say that to you. It's like, do it, but do your due diligence in individual therapy, in couples therapy, with a lawyer, with a healthcare lawyer, right? With all of those things, every possible difficult conversation that you never want to have. One of the things that I love, there's a book on collaborative divorce called A Parent's Guide to Bird Nesting, and I actually interviewed the author and the show on my podcast. And one of the things she did in her book, she doesn't even realize how brilliant it is she basically has this idea of divorce where you do bird nesting, where both parents rotate in and out of the home, and the children get to grow up in the family home. Because why should the children, who after all didn't make this decision, be the ones to have the burden of going like from Tuesday through Thursday to mom and Monday through Wednesday to dad or whatever, and flipping and leaving stuff behind and feeling unsettled. So instead, the parents should rotate in and out. That's her idea about divorce. It's not only hers, it's a pretty well-known form of divorce. And she basically has this bird nesting agreement where she pretty much puts down every single possible question that you could have. Should our kid take karate lessons? How will holidays go? How will vacations go? What if our kid doesn't want to go to college? What will happen to the college fund? I mean, like every single question that you could possibly think of is in that book. And then you sit down and you hammer through a bird nesting agreement. Of course, if you could do that, you possibly might not need to divorce. I mean, if you could do that without any help, then that's pretty impressive. Because I could imagine having that conversation with my husband and having quite a few hot button questions. I'm like, oh, I don't know. Do we agree on this? I'm not sure. Right? And we have a very functional marriage, but still. The idea is you hammer all that stuff out. And I don't know if something analogous exists in the grief literature, in the like remarriage, step-parenting literature. There were some documents, some things, but sitting down and hammering all that stuff out in advance. And then you're going into it with your eyes wide open. Because like I said, the Brady Bunch is fiction.
Right. Two last questions. One is, my father was not there for us after my mother died. He is now 79, and I want to bring it up, but my siblings think it's cruel to bring it up with an older person from a different generation who just simply didn't know better. But I don't want him to die and still have anger towards him about what he did.
So this is not a question I think we can answer in absentia. There's too many factors here. We don't know where your father is cognitively. I think it's something you sit down with a therapist and you talk through the pros and cons of. And if you did decide to go forward with saying it, then I think you'd have to do a lot of rehearsing and a lot of preparing and a lot of couching, and have your father have his own mental health professional helping him with this. There's too many factors here, I think, for anyone but your very own therapist to answer.
I think that's an excellent answer. And the last one is really a fun question. This person says she's a big fan of Dr. K's Storytime. What are your top 5 children's books that teach healthy coping skills?
So I'm going to answer this by not answering this. So every Monday night at 7 p.m. I do Dr. K's Story Club, where I teach the lost art of reading storybooks to kids and talking to kids about their big emotions with those storybooks. Now here's the thing that I do. Not one of the books I choose ever teaches coping skills. I don't use those books. I don't like Life Coaches in a Box. I don't like, the like child version of like Dale Carnegie, right? I read a really great story that just has a relatable character and just a great engaging tale. And then using that story, once we're attuned, because we're like in the same story, we talk about the coping skills then. I am not a big believer in a book that teaches coping skills. So if like I'm reading a book about moving, or I like certain authors, like I like Pat Miller a lot, I like Meg Medina a lot, I like Mo Willems, I adore, right? Like I have a lot.
You know that you did me in with Mo Willems because you got me hooked on him, and that was the end of me.
Awesome. I love Kevin Henkes, right? Like Kevin Hankey's wrote Wemberly Worried. It's about a little mouse who worries. Nowhere in the book does it say anything about what to do when you feel worries, right? You never see that, right? There are some great like theories for counselors, like Julia Cook theories, which are all about teaching different skills. But I don't find those stories. Those to me are teaching manuals with the story dressing up the teaching part, right? So to me, a great book is a great story. And then we can say, oh, so Wemberly was worried and she had a little Mr. Worry in her brain. And what do you think happened next? And how do you think she handled it? What was it like to be Wemberly, right? And we kind of go through it and then we talk about it, because I don't love teaching to kids. I don't like teach and preach, right? I like, let's talk, let's get curious, let's figure this out together.
I know I've asked you this 100 times. Do you have a list of your books anywhere?
Nope.
Okay.
They're just in my library.
Next thing I'm going to work on is I'm going to scroll through that feed, because people keep asking me about the books. I'm going to put them into my Amazon shop, because
one day I'm going to make an Amazon shop of like all my books and what I use them for.
In the meantime, I'm going to make a category in my Amazon shop called Dr. K's Story Time, because though every week I'm going in there. I should just go look through my Amazon orders, because like you read a book and I go order the book.
Right.
I also am a little bit crazy in love with storybooks for kids, because those are just so much better than these.
So stories are how we heal, right?
Wow. Okay, so we went through not all, but we
did a
through,
lot.
I have to say, a good portion of the questions. Really, really, really appreciate this. This is part 3 in a series. Part 1 and 2 are available on YouTube. I will be posting a link in my bio, hopefully a little bit later on tonight. I couldn't believe when I went on, I was like, oh my gosh, in my bio, my YouTube channel's not there. Okay. Now you notice, like, you know, sometimes it takes these things to notice. Thank you all for submitting your questions. We're going to still figure out what to do with the few. There were a few good ones that we didn't get to.
We'll have to just do a part 4 one day.
I feel like, though, and I will say this, I said this at the beginning, but I feel like there's a lot of growth within both of our communities. We are really learning together. We are growing together. I know I've gained so much from the questions that are asked. And I really feel, can you do part 4? We definitely might consider it. But I think that there's a lot here. I do want to just say for 2 seconds, number one is, if you have not listened to the Post-Traumatic Parenting podcast, it is my absolute favorite. I do tend to buy a lot of books because of it. And it also is the kind of thing where I don't suggest like doing something else while you're listening to it. It's not like this light story time kind of a podcast. It's something where genuinely you will walk out of each podcast with real skills. Like, it's not one of these fluffy things. And if you are a post-traumatic parent like I am, and like so many of us here are, we have so much to learn about ourselves all the time. I know that I've taken some of what I've heard in podcasts and walked into therapy session and gone, like, we're working together for all these years, but I never even thought that this is why I react this way.
Never made that connection.
Comes home with that, right? So much to learn, and I personally have grown so much. I also want to mention that next week, Monday, July 12th, we're going to be announcing it tomorrow, but you're here, you get to hear it a little early. We're going to be having our first Adult Grievers Summit. Did I just say first because I'm crazy? Yes. First Adult Grievers Summit for adults who are struggling with grief, namely parental grief, but much of the topics will be, overlapping in general with people are dealing with grief. And I will be announcing the lineup tomorrow, but I'm really excited. And can we out one of the lineups here? I basically did it. I called Dr. Koslowitz before we started this, and I said, I just need to make sure the date is good with you, because if it's good with you, I'll work on everything else. Right. So yes, Dr. Koslowitz is going to be one of our speakers on our summit. It's going to be something very special. It will not be on Instagram. You will sign up before it. It will be probably hosted by a completely different platform to allow for a lot more interactivity. Very excited about this. The surveys were mind-blowing. We got over 200. Can you believe that? Over 200 men and women who submitted their thoughts on adults and grief, and it was fascinating about the topics that they want covered, and we're going to try to obviously cover some of them, and that's why I say it's the first. So thank you for joining us tonight, and hopefully this live will save, and you'll be able to rewatch it later and tell all your friends. Take care. Have a good night.
Anybody, if you're not following me, you should know that we do make the post-traumatic parenting community, which is on my page, very interactive. I like to think of the podcast as sort of a talk show, except that no one's calling in, right? Like if you have a question, my best episodes, my best articles come from reader questions. Like I really mean it when I say, please message me your questions. DM me, ask me. If you want me to deal with an issue in Story Club, DM me. Be like, my kid's moving. What book could you read to help us open the conversation, right? Or whatever it is, because that's what I love. Same with my therapy Thursdays on Thursday night. You send me a question, I'll be like, that's a great topic. I've never talked about that. Because that's the goal. We're only as strong as our members.
Right.
I think for both of us, right?
I think that's, that's definitely why we share so many followers is in this context. Right. I think we like to grow and learn from each other. Thank you so much, all of you, for being here tonight. Take care.
Good night.
And we'll see you.